Incomplete endoscopic resection of colorectal polyps, a prospective quality assurance study. Introduction. Endoscopic screening for colorectal cancer, CRC, has been shown to reduce CRC incidence by 23% to 33% in randomized trials. This is achieved by resection, polypectomy of adenomas and serrated polyps, which are CRC precursors. However, there is growing concern that a substantial number of patients have residual polyp tissue after what is believed to be complete resection. Recent evidence shows that a significant number of polyps are incompletely removed. As many as 31% of large and sessile or flat polyps recur. Incomplete polypectomy may have significant clinical implications, potentially accounting for as many as 19% to 27% of cancers occurring before the next scheduled colonoscopy, interval cancer. Polypectomy technique varies between endoscopists. Different techniques may lead to important differences in the ability to remove polyps completely. The proportion of incompletely removed polyps has been shown to vary more than threefold between endoscopists. Systematic training and better techniques may improve polypectomy. For example, injection of submucosal fluid, endoscopic mucosal resection, EMR, may facilitate complete removal even in polyps of less than 1 centimeter in diameter. In order to improve the quality of care for patients with colorectal polyps, it is important to know the rate of incomplete resection. Traditionally, experienced endoscopists teach less experienced colleagues how to perform polypectomies. However, if the endoscopy technique is suboptimal, experience alone is not necessarily associated with high quality. Whether or not experience by itself is associated with incomplete resection of colorectal polyps is unknown. The aim of the present study was to estimate the rate of incomplete polyp removal and to determine risk factors associated with incomplete polyp resection at multiple centers and between endoscopists in Norway. Methods. The authors included patients aged 50 to 75 years with non-pedunculated polyps 5 millimeters or larger removed during colonoscopy at 4 hospitals in Norway. To evaluate completeness of polyp removal, biopsies from the resection margins were obtained after polypectomy. Logistic regression models were fitted to identify factors explaining incomplete resection. Results. 246 patients with 339 polyps underwent polypectomy between January 2015 and June 2017. A total of 12 polyps were excluded in the analysis due to biopsy electrocautery damage. 327 polyps in 246 patients were included in the analysis. The mean age of the patients was 67 years. About half of the patients were male. Overall, 54 polyps in 54 patients were incompletely resected. Histological diagnosis of the polyp, sessile serrated lesions versus adenoma, and polyp location, proximal versus distal colon, were independent risk factors for incomplete removal of polyps 5 to 19 millimeters. Board-certified endoscopists were not associated with lower rates of incomplete resection compared with trainees. Conclusion. Incomplete polyp resection was frequent after polypectomy in routine clinical practice. Serrated histology and proximal location were independent risk factors for incomplete resection. The performance of board-certified gastroenterologists was not superior to that of trainees.